I'm Sanjay Nigam. I'm a psychiatrist at Southern Illinois Associates in Maryville, Illinois. Today is my second podcast, and we are going to discuss treatment resistant depression and Spravato treatment. I will have some slides with this. And today's learning objectives are understanding the glutamate system, mechanism of esketamine or Spravato, and some look into some clinical evidence and practical implementations, look into some protocol, safety monitoring, and patient selection criteria. Major depressive disorder is a clinical global crisis. It is the leading cause of disability according to NIH, which is National Institute of Health, and World Health Organization. Approximately 21 million people suffer from depression every year in the United States. We have the treatment for depression, but our antidepressant medication lacks the efficacy to help all of our patients to achieve remission and response. That's where the definition of treatment-resistant depression has come into picture. Treatment-resistant depression is defined by FDA as any person who with a history of depression and currently in a depressed state has failed 2 or more antidepressant from 2 different classes and still having depression. Depression is not just being feeling sad or depressed, it is more than that. Approximately 33% of all our major depressive disorder meet the criteria of treatment-resistant depression during their illness. The patient population group is heterogeneous, varying from different pathophysiology and comorbidities and different treatment histories. An adequate treatment is defined when you, as a patient, has received an adequate dose and a adequate trial, which is usually defined as 4 to 8 weeks of treatment with each antidepressant. Looking into the evolution of pharmacotherapy, in 1950s, there was an accidental discovery while we're treating tuberculosis and schizophrenia that we found monoamine oxidase inhibitors like epronaiazide and tricyclic antidepressant like imipramine were having antidepressant effect. In 1987, fluoxetine was launched and the SSRI revolution happened. And it did help a lot of our patients. It has a better tolerability, better safety profile compared to our older tricyclic antidepressant and MAOI inhibitors. Few years later, in 1990s, serotonin norepinephrine reuptake inhibitor or dopamine and norepinephrine reuptake inhibitors were found and were very effective in a different side profile. In 2000, there was a paradigm shift happening because we were finding the monoamine neurotransmitters were not very helpful. They started to look into glutamate modulation, GABAergic system, and other neuromodulation techniques, including TMS. The ketamine lead to a glutamate revolution. It is a dissociative anesthesia, and in 1960s it was discovered to produce a rapid and robust antidepressant effect through the glutamatergic mechanism, which is entirely different from our traditional antidepressant. It leads to new era of depression research, and the breakthrough lead to esketamine. Esketamine is a S enantiomer of racemic ketamine, meaning it contains only one pharmacological active, which is a mirror image molecule. So ketamine has 2 molecules, you can say. One is R and one is S. They are mirror image, but they are not same. You take the R molecule out, what is left is S isomer, and that's what esketamine is. Ketamine is usually given IM or IV. It has very poor bioavailability when taken orally. Esketamine is a nasal spray, so it bypasses the liver metabolism, which is we call first pass hepatic metabolism, and it directly delivered to central nervous system because it bypasses the liver. In 2019, the FDA approved esketamine for the treatment for major depressive disorder with augmentation or in conjunction with oral antidepressant. Also, it got approval for improvement of depressive symptoms in a person who has acute suicidal ideation. It is not a substitute for hospitalization, so that's very important. The patient, the pharmacy, and the providers all have to enroll into RAMS program, which is Risk Evaluation Mitigation Program. It is designed to decrease the abuse and misuse of esketamine because ketamine has been found to have street drug value, so FDA did require that it is closely monitored and it is never given to a patient to take it home. Mechanism of action of esketamine, how does it work? We could say esketamine has three ways of working. One is a very rapid response, and then one is a short-term response, and then a long-term response. The short-term response happens as it being a NMDA receptor antagonist. It blocks the NMDA receptors, and especially on the GABAergic inhibitory neurons. So what does that mean to our patient is when they take the esketamine, there's a surge of glutamate and they started to feel better immediately. And these surges then lead to AMPA receptor, which we call AMPA receptors, to trigger excitatory neurons that lead to cascade of intracellular signaling and also lead to brain-derived neuropathic pathways, BDNF, which is a protein very essential to neuronal health and synaptic plasticity. This BDNF production leads to synaptogenesis, which means is a formation of new synaptic connections. It also leads to dendritic spinal growth, which means expansion of neuronal branching. Also can lead to reversal of stress-induced synaptic atrophy, which can lead to a long-term improvement in mood and depressive symptoms. The result is a very rapid restoration of scheduling is very important. I call it's a 2% commitment because you need to have a responsible adult who is going to drive you back home because of the risk of sedation and some cognitive impairment which happen within the first 2 hours of the treatment. So the first 4 weeks, we start esketamine twice a week. It can be started at low dose of 56 milligram or 84 milligram, and we continue twice a week of 84 milligram for the first 4 weeks, and then week 5 onward, it can be either 56 milligram or 84 milligram, and then in a maintenance phase after they are stabilized, it can be reduced to every week to every 2 weeks, depending on the response. Monitoring is very important. We do require the patient to be observed for 2 hours following administration. Blood pressure is monitored at baseline in 40 minutes and at discharge. In our practice, we do more often than 40 minutes because of the risk of dissociation and potential abuse. The monitoring is mandatory and has to be done in a clinical setting. Side effect, as we were mentioning, people do feel detached. People do feel floating, dreamlike. People feel these symptoms peaking in 30 to 40 minutes and usually resolve in 90 minutes to 2 hours. Severity decreases with repeated dosing. Dizziness is common. 20 to 30% of our patients do feel dizzy. Blood pressure elevation happens. We also look for elevated blood pressure causing any severe symptoms like chest pain or infusion, blood vision. There is a long-term some safety concern because of ketamine chronic abuse. There are some reports of ketamine-induced interstitial cystitis. We have not seen that in esketamine patient, but there is an increased urination because of the cognitive function, which peaks in about 60 minutes and come back to compared to placebo in about 2 hours. Because of the abuse potential, it is a Schedule 3 control medication, and the RAMS requirement for supervised administration to mitigate the diversion risk. That's the key takeaway from this talk one. It is not a complete talk. It's just an educational and introductory talk. If you don't know about Spravato, the key takeaway I would say is a novel mechanism. It works through a different system, through a glutamate, and it is much more effective than our traditional antidepressant. It has a rapid action, like unlike antidepressant, which take weeks. It start to work within hours to days and has a very rapid response. And it has a neuroplasticity with it. And there is a strong clinical evidence that esketamine is effective in both relapse prevention and methane augmentation. It is now also approved as a monotherapy. Most of the insurances do cover esketamine treatment. If you or your loved one are suffering from depression, which is not responding to 2 or more antidepressant, you can reach out to us at Southern Illinois Associates LLC. You can do an online scheduling through our website, www.sia-llc.net, or reach out to us via phone. Thank you. Please leave your comments and let me know if you want me to cover any topics, and I will try to do a video podcast on it.